I think regarding the STEMI situation and also other PCI, I think it's very important that we don't only look at the anatomy of the coronaries, but also take care of the paperwork and look at patient characteristics before, because in observational studies it's been noted that surprisingly many of the patients undergoing elective PCI or ACS are actually at high bleeding risk. This is almost half of the patients. And these patients have bleeding events after PCI with drug-eluting stents. You can see the percentage here. Most of them are, PARC 2 to 5 bleedings, usually PARC 3 to 5, which is the severe bleeding is around less than 5% or so, but still these patients bleed. And then if there is a bleeding after PCI, it's associated with higher increased mortality through several mechanisms. And I think which is also important is that the bleeding risk and ischemic risk go hand by hand, so that on the right side you can see the higher cohort, higher bleeding risk cohort. The score over 1 means a high bleeding risk according to the academic research consortium criteria, and the same patients have more device-oriented composite endpoints after stenting. So this brings us to the concept of metal-free PCI in this patient population. So we did the first randomized trial comparing DCB against stenting a few years ago, and we presented this 6 years ago in EuroPCR, and it was published in the Lancet the same year. So we included patients with either stable coronary artery disease or ACS, and randomized after predilatation either to paclitaxel-coated DCB or bare metal stent. We had to use bare metal stent because at the time in the guidelines DES was not indicated for high bleeding risk patients. We started this trial 2013. The mean diameter was about 3 millimeters, and there was only 2% of bailout stenting in the DCB arm because we randomized the patients after predilatation. And importantly, in this trial, the DAP duration was similar between the groups. It was 1 month in stable coronary artery disease and 6 months after ACS because of the bleeding risk. What we saw is the difference between the DCB arm and the BMS arm, which is not very surprising, but very low amount of adjudicated events in the DCB arm. This is MACE in follow-up up to 3 years. There is a statistical significance, and DCB was not only non-inferior but also superior against bare metal stent. About other trials, again, there is a subgroup analysis of the basket B small or basket small 2 trial. 20% of the patients had high bleeding risk, and interestingly, there was no mandatory dual antiplatelet regimen, but in the DCB arm, it was the usually recommended 4 weeks and 6 months after DS implantation and 12 months after ACS. And there was a trend towards less severe bleedings in the DCB arm as compared to DS arm. Of course, this is a hypothesis generating finding. But as we heard in the morning, there was also a very similar trend in the CAGE-3 trial in favor of DCB for less bleedings. And again, we will have a very interesting subgroup analysis of the solution de novo trial because in the ischemic endpoint target vessel failure, there was heterogeneity between DCB and DES groups, and no bleeding events is included in this analysis. So I think this will be very, very important subgroup analysis and quite a bit of patients also with HBR in this trial. So how about the dual antiplatelet therapy in this trial? This is unpublished data, but you can see that there is statistical significance between the solution DCB versus drug-eluting stent at 1 month, 6 months, but not anymore at 1 year. So perhaps there will be also less bleedings in the high bleeding risk cohort, given this shorter dual antiplatelet therapy. So what we know about optimal antiplatelet therapy after DCB-PCI? We have actually 3 consensus documents at the moment. We have the European consensus document, which recommends 4 weeks of dual antiplatelet therapy in ISR and de novo lesion after DCB-only PCI. The Japanese paper recommends 1 to 3 months dual antiplatelet therapy in CCS patients, and then we have the Asia Pacific document, which says that there is also the possibility of discontinuing antiplatelet agents, and even the single antiplatelet therapy could be feasible after DCB, given the trials, registry-based trials. And the latest document is the Academic Research Consortium paper, which states that the current consensus is 1 month in chronic coronary syndromes, but there are some potential advantages in HBR patients, including shortening of DAPT, less than 1 month, the possibility of stopping antiplatelet therapy during the first month, and even the single antiplatelet therapy could be feasible in selected populations. But we have still outstanding remaining questions about the optimal antiplatelet duration in these patients. So, can we do DCB-PCI with using only single antiplatelet therapy? I think the hypothesis is that because dual antiplatelet therapy was developed for prevention of stent thrombosis, and it was later found beneficial or also for ACS population, we have a possibility that we can do angioplasty without dual antiplatelet therapy. And this could potentially lead to fewer bleeding events in high bleeding risk population. So do we have any data on this concept? We have a few observational studies. This is from our group, 172 patients. We started this single antiplatelets already 2011. In selected patients, almost all had high bleeding risk. Also ACS patients, almost 60%, almost all were de novo lesions, and 50% also had periprocedural dual antiplatelet therapy, meaning a loading dose of clopidogrel or ticagrelor or Genrexal infusion during the PCI, but all went home with single antiplatelets. And there were no acute occlusions of the treated vessels, and the MACE and bleeding rates were quite, I think, acceptable. Then there is another paper from Italy, 107 patients from Bernardo Cortese's group, and also Patrick is involved here. And they used less aspirin and more clopidogrel after DCB-only PCI. And again, there were no reported acute occlusions of the vessels. These patients are very selected, high-risk patients, a lot of cancer. Almost all have high bleeding risk. And then there is a subgroup analysis of the sirolimus DCB observational study. 113 patients had only single antiplatelet after PCI, and also in that paper it was safe to do so. So we have these 3 papers, but we need again randomized trial. So the answer hopefully will be this debate trial, which randomizes patients with stable coronary artery disease or ACS and high bleeding risk after successful predilatation to paclitaxel-coated sequence-release DCB or any DS with a 1 month DAPT for CMARC, and there is a different antiplatelet regimen in the group, so that stable patients receiving DCB also have single antiplatelet therapy after PCI, 1 month DAPT after DCB in ACS population, and then longer guideline recommended dual antiplatelet therapy in the DS arm. And net clinical outcome comprising of MACE and BARC bleedings is the primary endpoint, and we are looking at the non-inferiority. And if it's met, then we are looking for superiority of DCB. We have centers from Finland, France, Spain, and hopefully in the future also Germany and Australia can participate. Then there's another interesting trial from Korea. It's a larger trial. Actually, the randomization in this trial is done before lesion preparation, but this means that in the DCB arm there will be also drug-eluting stents affecting the antiplatelet treatment in this arm, but this is a strategy trial. If I understood correctly, in DCB arm there will be 1 month dual antiplatelet therapy, and in DS arm 3 months dual antiplatelet therapy. And they are looking as a primary endpoint only an ischemic endpoint, target vessel failure, and then they have bleeding events as a secondary endpoint. I think they have randomized the majority of the patients at the moment, but I think it will be interesting paper. So finally, I would like to share a very interesting case. This is an elderly man with a very severe thrombocytopenia, but very severe ischemic symptoms. He actually couldn't do anything but sitting at home because of angina. There is a very tight right coronary artery lesion and then calcified distal left main. So what do you do with this patient? Is it only medical treatment, or can you still do something? I think CABG is not maybe optimal treatment in this patient given the thrombocytopenia. So what we actually did, and this is to remind, the most severe bleeding risk factor is thrombocytopenia, and after that kidney failure. And for example, anticoagulation is not that significant as compared to kidney failure. I think this was a little bit, I think, surprising for me at least. But what we did, we gave only aspirin and then Kengrexal infusion, half dose actually, heparinized the patient, gave some thrombocytes before PCI, and then prepared the lesion with the scoring balloon and paclitaxel-coated balloon. This is the result. And then we did rotablation to left main, LAD. We did another rotablation to left main, intermediate branch. We used NC ballooning, and for the left main cutting balloon, and then all DCB. And this is the final result, and there was no bleeding or ischemic event during the 1 year follow-up. So I would like to conclude that 40% of the contemporary PCI patients are at high bleeding risk. I think it's one of the most appealing targets, sweet spots for DCB, only PCI. There are patients needing next day, next week surgery. There are cancer patients and other bleeding risk patients. And the benefit is to do in a very high risk patient single antiplatelet therapy, or stop everything if there is a severe bleeding event, and hopefully get more information about this approach in the debate trial. Thank you.